Okay, it's my pleasure to introduce our next speaker from Wake Radiology, my colleague, Dr. Rance Douglas. He's going to be speaking to you about common diseases and associated imaging with special attention to the chest and heart. He's one of the smartest guys I know, so I think you'll enjoy this topic.
In 2002, I actually had the opportunity to join a research group that was looking at what we thought was going to be an exciting new technology. That was the fast CT scanners were actually starting to be able to image the heart. And so I got involved in a research mode. It's now, I can't believe it's been 6 years already. But what amazed me early on was that there were a lot of misconceptions. Even after I had been with a research project about a year, I realized there's a tremendous misconception from the lay public all the way up to cardiology about the proper way to risk stratify and how we should deal with this very common problem. And in fact, since about 2004, when I've started giving this talk, I've probably given this similar lecture 50 times, all the way from lay public groups all the way up to cardiologists. Now, I'm constantly amazed about the confusions, the misconceptions, and some of the questions that I get. And now, today I kind of feel like Al Gore on the trail, given my little spiel here. And we've kind of gone, it kind of goes in peaks and valleys. I think in 2005, we were trying to enroll patients in a research trial that I had going on, and I was having a real hard time getting anyone interested even in going to a CT scanner to have their heart done. And on September 12th, I'm sitting there bemoaning, actually talking to one of the technologists, what are we going to do? How am I going to get patients into my trial here? And all of a sudden, all four of our phone rang simultaneously, and it turned out that Oprah had just had hers done, and it was on that segment that afternoon. And so 2005 goes along, and for a while it seemed like every week I was getting called by the NNO, or all of a sudden I'm at work one day and the hospital publicist brings down all their cameras and they want to take my picture. Well, now fast forward 2 years, and we seem the cycle has gone the other way. In fact, I've read 3 op-ed pieces in the last week pointing out this test, what I'm going to talk about today, as like a major culprit in rising healthcare costs and unproven technology. So, and I like giving the talk to this size group because rather than let you ask me questions, I like to ask you guys questions. So how many of you have heard of coronary calcium scoring or heart CT scanning? It's pretty good. How many of you have ever ordered one? Yeah, and that's, how many of you have heard that it's accurate and maybe a useful test?
Which one?
Calcium scoring or coronary CTA? Either one. Anyone? How many have read a peer-reviewed journal article or versus how many of you have gotten all your information from the lay press? How many of you, raise your hand, how many have read a peer-reviewed article on this topic? And how many think they've heard a lot about it, but it's all from the lay press? Yeah, so I think, and hopefully as we go through today, I think the Oprah spot is probably not right, but I also think what we're reading today, in it's just kind of what you read in the lay press, you're either the devil or you're the angel, but there's the reality, and there's still a lot of misconceptions out there. And so hopefully we're going to clear up a little bit of that as we move along here. So I think what we need to ask ourselves, I'm going to spend most of the time on asymptomatic screening, and there's about 5 minutes of this that has nothing to do with radiology, but I'm going to stop and wake you guys up because there's 5 minutes of this that is just crucial in terms of accurately risk stratifying your patients, and all of you guys are as you're going to see in a minute, on the forefront of preventing cardiac disease, and risk stratification is crucial. So if you're going to sleep through the rest, there's about 5 minutes in here, has nothing to do with radiology. I'm going to wake you up and you got to pay attention. But so let's talk about asymptomatic screening, or trying to help with our risk stratification. And I think anytime we're talking about ordering expensive tests, we should be asking ourselves 2 questions. Why do we need to do this? And more importantly, will the results of my test, when I order this imaging test, how is it going to affect what I'm going to do with that patient? And if you can't answer these two questions, and if I don't answer them during this lecture, then there's no business even thinking about it. But that's not only for what I'm doing, that's for all imaging. Okay? So what about the one disease that I'm talking about, acute coronary syndrome? And I think probably most of you know that coronary heart disease is the leading cause of death in the U.S. It's also by far the most expensive disease in the U.S. And in fact, more imaging dollars are spent on just echocardiography alone than all of CT and MRI. So I mean, it's an incredibly common disease, and it's incredibly expensive. Okay, and what we need to know is there will be 700,000 heart attacks, give or take, in the U.S. next year. And is 50% of those, their first symptom that they have anything wrong with them will be they'll either drop dead or they'll have a heart attack. And of the 700,000, 1/3 of those patients are going to be dead in 12 months. Okay, and that's why I say you guys play a critical role in this, because so many patients that have devastating, myocardial infarction, they have their event before they're going to see cardiology, before they're going to see anyone perhaps than their primary care physician. So it's critical that you guys understand what role you can play in this very common disease process. Okay, so, and the other thing you need to be aware of, and you need to be proud of the fact, is that preventative therapies work, okay? And you guys need to know these statistics, okay? There's good evidence that if you decrease someone's LDL cholesterol 1%, you decrease their heart attack risk 1%. And in fact, there is no lower limit to that. The lower you drive LDL cholesterol, the lower the heart attack. So if you take someone from LDL 200 to 100, you've decreased their risk 50%. If you start with a patient with LDL of 100, okay, great LDL, take them to 50, you've decreased that patient's risk 50%. In fact, there was an article out this week showing if you put normal cholesterol people on statin therapy, you in fact decrease their heart attack risk. The lower LDL goes, the less your risk of myocardial infarction. Okay? And the other thing you need to know, and you guys know this, is low-dose aspirin also helps prevent heart attacks. So on the preventative side, we have great therapies. Okay? Statin therapy works despite some of the stuff you hear in the lay press. I mean, there's been multiple articles that show basically this point right here. And aspirin works, okay? Those save lives, decrease morbidity. Now, on the other hand, and I think you need to be aware of this, is there is no evidence out there, none, that putting a stent in someone in the long term is going to decrease their morbidity or their mortality. Okay, so when that patient that you sent to the cardiologist comes back to you with a stent in their LAD, their long-term risk of having myocardial infarction is exactly the same as before you sent them to the... Now, hopefully their anginal symptoms are much better, but the point of fact is what saves lives is these simple therapies. Okay, now and then I give this to cardiologists too, and they say, well, what about, and to be fair to them, if you're having an acute MI, revascularization is critical. They play a critical role in acute patients who come in because by reopening the vessel, it saves heart muscle. But on your perspective, the stable outpatient, okay, what you need to know is these therapies, these simple therapies, save lives, not the interventional cardiologist. Very important for you. And I've had guys, I've given this talk to lay audiences, okay, and I've had people follow me out to the car. And this guy said, well, they put 3 stents in my LAD. I'm normal now. I said, well, sir, what's your cholesterol now? I don't know. When's the last time you followed up with your regular doctor? Are you on your statin therapy? I didn't know I needed to do that. You know, so that, and that's, again, that's not probably his cardiologist's fault. His cardiologist isn't telling him not to take his medicine, not to follow up, but there's this perception, I think, in the lay public that somehow we put this little metal stent in and you're cured. And I also think we, all of us, sometimes fall into that. Oh, it's being handled by cardiology or whatever, you know. I mean, and you guys are the ones that actually do the line, you know, the work of making sure that people are taking their medicines and keeping their cholesterol at low levels, the ones that are at high risk. Okay, so very, very important. Okay, now, here's where you need to wake up. How many of you guys use the Framingham risk calculator every single day in your practice? Yeah, and that's what I get normally. About 2 or 3 people actually use the risk calculator. And you should be doing, I mean, forget about all this imaging stuff I'm going to talk about. At the minimum, you need to be risk stratifying people using the known methods that we have that are free and treating them based on the treatment recommendations from the NIH, which is based on this. So how does Framingham, you go, basically, I used to give out little cards, didn't I, Amy? I was like, you got to take this card because it has the website so you can get to the Framingham risk calculator and you can treat people appropriately. You can treat their cholesterol based on science. So how does it work? You go to the website, you fill out, you need to know 6 things. You fill out the data. Okay, you hit calculate your 10-year risk. Boom, and it gives you that. It gives you a 10-year risk profile. Okay, so then what do you do with that information after you've done the framing? Again, this is free. You go on Google for 5 seconds, you get this done. What do you do with that information? Well, actually, now there's a blue ribbon panel that has been working since the early 2000s, and now they're on actually their 3rd iteration, the National Institute of Health Acute Adult Treatment Panel. Basically, about every 2 or 3 years, they give their recommendations of how you should treat someone's cholesterol, and it's based on basically their Framingham risk score. Okay, so in 2004 was about the last time they gave their last update. Basically, they broke people into 4 categories. I hope no one's asleep for this, because this is the most important part of this whole talk. Okay, so Framingham risk, okay? Framingham risk is greater than 20, so you do the risk calculator, it's more than 20%, or you have a coronary artery disease equivalent, which is you have known peripheral vascular disease or these other problems, then your risk is high, okay? Moderately high risk, your calculator is 10 to 20%, and you have 2 or more major risk factors listed here. Moderate Framingham risk, again, calculator less than 10%, but multiple risk factors, and low risk. Okay, then what do you do with this information? So I've done my calculator. I've used, now I look at the treatment guidelines, and the treatment guidelines basically tell you what you should be doing with your LDL treatment. Okay, so right here, you figure out their high risk. Their LDL goal should be between 70 and 100 milligrams per deciliter, LDL cholesterol. If they're above 100, those patients need to be treated. Moderately high risk, okay, and this is the card I used to put on one side the website for the Framingham calculator, and on the other, this card. And I said, I challenge every group of family doctors, nurse practitioners, you need to be doing this on all your patients or you're not treating them correctly. Okay? These are the guidelines of how you need to treat those people. Okay, so now those of you who, like me, my son had a football game in Charlotte. So any of you that got home at 2 a.m. like I did, you can go back to sleep because this is the most important part of this whole talk. Okay, so but is that it? So we're done, right? We can stop this lecture. I told you what you need to do to properly risk stratify all of your patients in your clinic. Well, so the question was, is that enough? And I love this. I stole this slide from Rumsberger. He's a cardiologist, a big proponent of calcium scoring. He said, well, let's just look at this anecdotally. We all have these situations. Let's just compare 2 prominent guys. They both had multiple risk factors. Both of them, you know, at risk for coronary artery disease, but one basically had a midlife conversion, became a marathon runner. The other guy did nothing, still smoked cigars, drank too much. So who would you predict would have a heart attack? And he said, so the problem with Framingham is it's good, and it's scientifically proven, but is that enough? I mean, we all have these anecdotal reports where we have patients come to us, they say, oh, I had a stress test a month ago, and you look at their normal physical, yearly physical, and a month later, they've had a huge AMI. I mean, how many of you had patients like that? Probably everyone in this room has had stories like that. So the question is, with just Framingham, is that enough? Or are there some patients that might benefit from more risk stratification? That's the question. Okay, and that's anecdotal. It's kind of funny. I like Rumsberger. He's a good lecturer. But is there scientific evidence that might support that maybe just doing the Framingham risk calculator isn't enough on some patients? And Acosta and his colleagues at the University of Wisconsin looked at this exact problem about 5 years ago at University of Wisconsin Hospital, and they said, let's look at over a year all the younger patients who come into our hospital with a heart attack. Let's look at just those patients and find out, could we have predicted using Framingham that they were going to have a heart attack and know that they were going to have a problem beforehand? And what he finds is, if you look at these patients, so these are all patients that we know had a heart attack. We know the end outcome was bad. They had bad disease. And if we go back now and look at them and say, could we have predicted it? What we find is we would have done, with just Framingham risk analysis, we would have done a really bad job trying to predict beforehand whether these patients were going to have a heart attack or not. So then the question becomes, well, is there some subset of patients that we might benefit by doing more than just standard Framingham? Okay, now I need to digress a little. Okay, why is there so much misconception about a lot of what's going on? Well, I think the problem for me was in 2002, I was remembering coronary artery disease from my med school days, which unfortunately I was getting to be a long time ago. But what I was taught about the pathophysiology of atherosclerosis actually turned out to be wrong. What I learned in medical school was a coronary artery disease was a lot like a rusty pipe. Okay, you had like these plaques building up over decades and years, and slowly the artery got narrow and narrow, and then that's why you got angina, because the artery got real narrow, and you started having chest pain, and then eventually the thing got so narrow it clotted off and you had a heart attack. That's what I learned. Unfortunately, that's wrong. Okay, what really happens is these plaques develop in multiple places all through your vessels. And the bottom line is any of those plaques can rupture all at once, and you can go from a narrowing of 10%, 20% to complete occlusion in 5 minutes. And in fact, usually, the majority of the time, the plaque that causes the heart attack is not the one where the narrowing is. Basically, a plaque that causes very little narrowing. You have these plaques in the wall of the vessel. Okay, it's causing no problem. 5 minutes before the guy drops dead, that thing is causing no problem. It's narrowing the lumen 10%, 20%. And then for reasons that we don't know fully, that plaque ruptures and you form a clot right there. And you go from an insignificant little plaque to complete vascular occlusion and myocardial infarction. Okay, so the point is, any plaque can be dangerous, whether it's causing a narrowing or not. That's going to be very important in a minute when we talk about stress testing, okay? So plaque rupture causes heart attack. Okay, and so this is just to reiterate here. Got ahead of myself a little bit, but I want to get to the bottom here. The bottom line is, if you take patients to the cath lab that have acute coronary syndrome, okay, and you give them thrombolytic therapy, or a lot of times by the time you get there and you squirt them, 2/3 of those patients do not have a stenosis. The vessel where they infarcted, there's no stenosis. Okay, so having a stenosis is not a prerequisite to having a heart attack. And in fact, most patients that have acute coronary syndrome do not have a high-grade stenosis in the territory where they had a heart attack. Very important for you to know that. Why? Well, because as you might predict, okay, a stress test, then how does a stress test work? Stress test, you put someone on the treadmill, work them, and you're looking for areas where there's narrowing, right? If you have a narrowing, they can't get enough blood flow past that narrowing, they get angina symptoms, and lo and behold, you detect that they have bad disease. The problem with that is, by the time you get those narrowings, you have 5,000 plaques all over your vessels everywhere. So what you're detecting usually is people with very advanced disease. And there's tons of people that are at high risk. It's not saying they need a stent. There's nothing to stent, but they need big-time preventative therapy with statins and aspirin. They need these things long before they have a stenosis. Okay? Okay, and as I said, again, we're just driving this point home. And in our own, now we looked at several hundred cases where we went back. What we find is 83% of our patients that have significant coronary plaque by CT, which puts them into an elevated risk profile, will have a negative stress test. And actually Berman and the UCLA group, who have looked at thousands of patients, found about the same thing. About 80% of patients that have significant coronary artery disease, you put them on a treadmill, they're normal. Okay, and there's no surprise. The pathophysiology, you get a heart attack because you have plaque rupture and you clot off the whole vessel. Okay, you don't need to have a stenosis to have a heart attack. Okay, so basically Berman has been a leading proponent. He's a cardiologist that does both nuclear cardiology and CT. Has been beating this drum for years. Basically, a majority of patients with a very high long-term risk of having a heart attack will have a negative stress test. Okay, and a negative stress test means nothing in terms of whether you have significant coronary artery disease. And in fact, there are multiple papers that show stress testing is it's a good test for detecting stenosis, a good test for detecting whether you have a stenosis. Very poor predictor long term of who's going to have a heart attack 3 years from now, 5 years from now. Okay, so maybe there is a role for this calcium scoring, maybe. Okay, and what I see now just drives me nuts in the lay press. I've seen 5 articles in the last 6 months in the lay press. Oh, it's unproven. Unproven technology. There's never been outcome determination. Well, I can tell you that there have been, in the last 10 years, over 1,000 peer-reviewed articles that show utility of this test in the last 10 years alone. And the bottom line is this is not a scientific conundrum. It's a reimbursement issue. To offer this to everyone who would want it under insurance is a big bill. And that's true. Okay, so what is a calcium score? Basically, it's not a test for stenosis, because I said stenosis isn't going to predict whether you're going to have a heart attack. What I'm trying to do is figure out your total plaque burden. How much plaque is in the coronary arteries? Okay, and the other thing you need to know is that it's pretty easy, technically not that demanding to do. And it's poorly reimbursed by insurance. Okay, so let's just look at what we do. Basically, we take my Cine's not running, but that's okay. We take a bunch of CT pictures and we find the little calcified plaques, which show up really well on X-ray. We find them all and we calculate the total number of plaques in your coronary arteries, and we get from that is an Agatston score. And I always have to digress here because I love Arthur Agatston. How many of you know who Arthur Agatston is? Yeah, you raised your hand.
No, I'm shaking my head.
No, behind you.
Is he the one with the South Beach?
Very good. South Beach diet author. And in fact, but early in the 1980s, Arthur Agatston did some pioneering work on calcium CT scoring. And unfortunately, he did about 3 or 4 years of really good, important research, And then unfortunately, he got kind of sidetracked on a lot better stuff, which was the South Beach diet. And we kind of lost him from the coronary CT fold, and he went on to bigger and better things. But because of his pioneering work, our scoring system is actually named after Arthur Agatston, the same one of the South Beach diet. So what do? We add up, we find all the calcified plaques, we add up your total plaque burden. Okay, and we get this score, and the score can be anywhere from 0 up to, we had our all-time record last week, 22,000. So scores can range from 0 into the thousands, and what we're going to talk about what these scores mean. But 0's good, and the higher it gets, the worse it is. Basically, the more plaques you have, the more chance one of those is going to rupture, and you're going to have a heart attack. Okay, pretty simple. Okay, and what does a coronary calcium do? It predicts your probability. Not only does it predict whether you're going to have a heart attack, it also is a pretty good predictor of whether you're going to have a stenosis and need a stent. We're going to talk about that a little bit more later. It's the single, I used to qualify this, but there's now so much evidence out there. It's the single best predictor long-term of whether you'll have a heart attack. Of any physical risk factor, any of that, any other test, if you could only have one thing, the best predictor of your long-term risk of having a heart attack is your coronary plaque burden or your coronary calcium score. Okay, and then what I say is, and we're going to back this up with the American Heart Association guidelines, is that basically Framingham is good, it works, it's proven, but calcium scoring can be used in conjunction with that to fine-tune your risk stratification. Okay, so let's take a case example. Actually, this is actually a guy who came to me and said, you know, I've been back and forth about whether I should go on cholesterol-lowering medicines or not. Okay, and then if you looked at him, he's in the moderate risk group because he has 2 risk factors, less than 10%. You need to know the Framingham risk and the NIH ATP3 guidelines, right? So I can look at him, and I know that he's in the moderate risk group, and I think I put a slide. So he's right here. His LDL goal is 130. He should be on meds if he's 160, and his LDL cholesterol is 148. So he's one of these patients that sits on the fence here. Do I put this guy on cholesterol-lowering medicine? For 2 years, he had been told, oh, it's not too bad. You know, we'll do diet and exercise. So the question is that good enough for this guy? What is his real risk? He's kind of in the middle here. Okay, and these, again, question number 2 at the beginning of this lecture, right, was how is it going to affect my patient management? Guy's LDL cholesterol is 220. He's going to be on high-dose statins. He doesn't need a calcium score. His LDL cholesterol is 90. It's not going to affect what you're going to do, most likely. But there are patients who you're in this gray zone. Okay, he's kind of on the fence. Does he need therapy? Are we doing okay? Should I encourage him with his diet and exercise? These are the perfect candidates, I think, for this test. Okay, so you tell the guy, this test is probably not going to be covered by your insurance, but it costs $350. So he looked at it and said, well, my copay for my statins is $68 a month. They just put me on it last month. I don't really want to take this medicine, and it's $68 a month. So you think about that. It's $350 for the calcium score, but if he doesn't need that medicine, he recoups that in about less than 6 months, right? On the other hand, he was put on like low dose, the lowest starting dose of lovastatin. So is that enough for him? I mean, maybe if his risk is high, you probably don't want him on the lowest starting dose, right? So we do his calcium score. I kind of talked him into it. I said, this might be useful for you. And basically, we found that he did have some coronary artery plaques. So what do we do with that information? We get an Agatston score, and the score was 121, which I said, usually for intermediate risk patients, if the score is over 100, that's going to be significant. But the other thing we can do is we use databases. There's actually a big European database and the Mayo Clinic database, and we can tell him, compared to other patients, where do you stack up? And he was actually in about the 80th percentile plaque burden for his age. So what I can tell him is that, in fact, his risk is not moderate. His risk is actually high. I can tell him confidently that his risk is not moderate, although his Framingham calculation is moderate, that his true risk is much higher. Okay, and he basically has gone on they increased his statin dose, and he actually started taking it, because I think a lot of the problem was he didn't think he needed it, and he did quite well, and he's started biking. He actually crashed his bike 2 months ago and dislocated his shoulder, but I guess I shouldn't tell that part of the story. But he's been now 2 years, he's kept his weight off, and his LDL is really quite good now. So if we took him from 148 to 86, we've decreased his long-term MI risk about 40%, which is significant. What does the American Heart Association say? It says a calcium score of 0 makes atherosclerotic plaque, vulnerable plaque MI incredibly unlikely. Okay, the likelihood of there's going to be a stenosis needing a stent, very unlikely. Okay, and what I tell patients is your risk, if your calcium score is 0, your risk of having an MI in the next 3 to 4 years is 0.1% per year or less. 0.1% per year or less. Okay? And about 60% of the patients who come to us end up having a calcium score of 0. So it can be very useful to reassure those patients, very useful to reassure patients, even ones that with kind of really weird, atypical, chest that doesn't sound cardiac, but calcium score is 0. That information alone is more accurate than any other diagnostic tests that we have right now, any stress testing. Now, what if your calcium score is elevated? Well, the American Heart Association basically reiterates what I say, is that your score over 100, if you have risk factors. Again, I'm not advocating we do this on the whole population, and I think a lot of the reasons we've had these insurance problems is the concern is we're just going to start indiscriminately scanning every patient in the country. But so a patient that has risk factors has legitimate chance of having disease if their calcium score is over 100, or if they're over the 75th percentile for their age, they are high risk. So they go from being sort of moderate or moderately high into the high risk category. Okay? And what they say is that patients at intermediate risk, calcium scoring should be considered for further risk stratification. Okay, so what do I tell patients? Again, calcium score is 0. That fact alone, that single bit of information alone is more accurate in negatively predicting their long-term outcome than anything else that we have. And I tell patients, your risk next year of having a heart attack is 0.1%. And again, we think the data is good at least for 3 or 4 years. I wouldn't recommend repeating the test probably at least for 5 years. You can tell patients in the near term, 3, 4, 5 years, their risk is incredibly low. And then again, just to reiterate, calcium score over 100 and 75%, higher than 75% rank, those patients are at high risk and they need to be treated aggressively, as if they are high-risk patients. Okay, and then back to this, not covered by insurance usually. We charge at our facility $350. It varies a little. Some places are a little bit more expensive. But again, if you think about what co-pays are for statin and the number of patients that get myalgias and fatigue symptoms from their statin therapy, there are certainly patients that can benefit. And it's cost effective for them. If they don't need the medication, they save a ton of money. And again, we usually don't accept patients unless they have physician referral. The reason why is if you have a positive score, I don't care about the number. What I want is for you guys to risk stratify appropriately and treat appropriately. So it's a conversation between the patient and their doctor about their statin therapy. It's not to take to a cocktail party and say, oh, my score was 0. I mean, we're trying to make real clinical decisions, or we don't need to be ordering the test, right? It's patients that you're considering therapy or considering change in therapy who need to have this test, not just the general public off the street. How am I doing on time?
You're okay, because we already had our question and answer.
Okay, so I'm going to change gears and I'm going to go more quickly. I think this was the more important part for you out here is risk stratification. I'm going to talk a little bit about coronary CT angiography. Probably not as important for you on a day-to-day basis, although I think there's so much misinformation about this procedure that I want you guys to be just a little bit better educated than what you're going to read from like the op-ed pieces in the NNO. So first we'll do conclusions here. I think I've killed that horse enough. So see coronary scoring and CT angiography for patients now that are symptomatic. Again, I'm changing gears. We talked about risk stratification and primarily asymptomatic patients. What do we do with what about patients who come to my office? 2 days ago I had this funny chest heaviness and I feel fine now, but I'm really worried, doctor. What do you do with those patients? Okay, well, what I'm going to try to drive home is that this test, when it's negative, is extremely accurate. I already told you, forget about CT angiography. If I told you your calcium score is 0, I can exclude the fact you having significant disease better than any other non-invasive diagnostic test we have. A calcium score of 0 has a higher negative predictive factor than the stress test does. So forget about if I just do a calcium score, that has, and it's low or no 0, it's incredibly high negative predictive value. But now I'm going to add on to that my coronary CT angiogram and give you another test that's has an incredibly high negative predictive value. So you're going to get 2 tests here that we're going to talk about. And then I say, who's best suited for this? Well, think through this for me. Think through this problem with me. What we want here is a negative test. Okay, I told you the negative test is incredibly high negative predictive value. You can feel confident telling your patients you do not have significant coronary artery disease when this is normal. What happens though in the patients that I diagnose as stenosis? Have I done them that much good? And the answer is no, because a lot of those patients still need a stress test to find out whether it's actually causing anginal symptoms and ischemia, and I can't treat their lesion. So the ones I want to try to pull out are the ones that we think there's a good chance this is going to be negative. Because a negative, I can reassure that patient they don't need any further workup. But when I get a positive patient, those patients are going to probably get all the same workup that they were going to get from cardiology anyways. And this is where you see this like real division. People say, oh, it's incredibly wasteful. It's adding another test. Well, it depends which patients you pull out. And if you look in I log all of ours. 85% of the cases that I do are negative. So what I do, if I can catch that patient population, especially the ones that come to the ED who are going to get admitted for 24 hours. We've looked at that data. It's $25,000 to $30,000 on average for the patient for an overnight admission to get a stress test the next day. Okay, so if I can capture those up front, do a $1,000 test and get them out of there, I have an incredible opportunity to save money. But what people confuse is it's all in which patients you select out. So in the high likelihood of negative, first of all, my negative result is more accurate than a stress test. But second of all, I have an incredible opportunity here to bypass the whole, I mean, it's a monolith, this unbelievable system we've worked with observation units, multiple stress. I mean, I see these diabetic patients getting stress tests every year, being admitted for overnight observation. We've created this Titanic over here, and what I find is the vast majority of patients that get thrown onto that ship are normal. And if I could find those patients before they get thrown in there, we could do some good here. And I'm getting a little bit like Al Gore now, aren't I? Okay, so I told you I'm going to do 2 tests. They both have very high negative predictive value. Calcium scoring alone, very high negative predictive value. Coronary angiography, on the other hand, high negative predictive value. Okay, so now let's break it out here for just a minute. You say, well, how can a stupid $350 test that I can do in 2 minutes be that accurate? How can that be better than stress testing? Well, let me tell you that those studies have been done. Okay? In Europe and in the US, Budoff out in California and the Munich group, here's what they did. They went to the ER. Okay, and they have patients in the ER. They've had their full workup, stress test, cardiology evaluation. These patients are going to the cath lab. And they had someone right outside the CT and said, wait a second. Before you take that guy into the cath lab, we just want to get a calcium score on him. Give us 5 minutes. Okay, and so Budov's group actually looked at 1,800 patients, again, fully evaluated, going to the cath lab. We want to get a calcium score on them. The Munich group, over 2,000 patients. So we have in aggregate about 4,000 patients with cath correlation. What did they find? They found that if the calcium score was 0, that predicted a negative cath with about a 97.8%, if you aggregate here, about 98% negative predictive value just with a calcium score of 0. So that if you could have done just the calcium score, that would have been more accurate than anything else you could have done. If it's 0, the odds of you having a positive cath. Now, we're not talking about squirrely chest pain. We're talking about guys in the ER admitted for chest pain. Calcium score is 0, excluded that they had a stenosis 98% of the time. So think about extrapolating that out into patients that are low-risk patients. I mean, you're talking about 99% or better negative predictive value of them having a significant lesion. Okay? And then they said, well, let's just have a magic world here. Let's say we can't do any cardiac workup. All we have is a CT scanner, and all we can get is a calcium score. And they said, let's just take a cutoff number. Let's say, about 90. If your calcium score is 90, you go to the cath lab. If your calcium score is less than 90, we're sending you home. What would happen in that magic world if that was our whole workup? You get nothing else. You just get EKG and labs to make sure you're not STEMI. And then if you don't have that, you get a calcium score. And if it's less than 90, you go home. Well, how would that do? How would that diagnostic test stack up against what we do now?
Please define sensitive and specific. What are they actually sensitive and specific?
Yeah, it was for a stenosis of greater than 70% at cath.
So
Right.
You're talking about using the gold standard in the system that you're disputing as the gold standard.
Yeah, I mean, there's some problems, but basically, but that's all we had. I mean, they were comparing it to whether they thought they had a cath lesion that was going to be significant enough to potentially warrant. All those obviously don't get stented.
That's really what the outcome is, whether they want.
Right, and that's actually some of the, and that's some of the issue with why it's not reimbursed. That's exactly right. And those studies are harder. It's harder to do those is the problem. But that's exactly right. And that's actually the criticism that has been laid on this test. But let's just say, though, let's compare now my 90, less than 90 versus stress testing. And let's say the prediction, what we're trying to predict, though, is if we send that patient to cath, that they're going to have a positive cath, which is a significant stenosis. That's your endpoint, basically, right? And basically what they said, using that criteria, but that's what a stress test is doing, right? You're trying to predict whether you need to send that guy on to cath. Correct?
And you're terming this as basically a fancy stress test for the same outcome.
Yeah, right. Except that the long-term, my prediction, I can give that guy, I can tell him his outcome of MI risk is 0.1% per year if it's 0. Stress tests can't do that. His long-term prediction of MI, I know what it is, and a stress test has no idea. Does that make sense? So not only do I predict whether he has a stenosis, I can also predict his risk going forward of having MI.
See, one of the problems I have in what you're saying is that in any scientific study, you not only have to have data, but you have to have a physiological explanation
Right.
of what it means. Because data by itself can't be interpreted physiologically. When you say you've got so much calcium, you're trying to figure out what does that mean when you say somebody has plaques and stuff, in atherosclerosis by all these tests we do.
Right.
We're saying that's not really what kills it. So what is it about having calcium there that physiologically tells us there's going to be a plaque rupture that we don't already know? That's just part of the plaque process.
Well, we do know the outcomes of what will happen to that patient. I mean, those studies have been done with tens of thousands of patients. I can tell you that if your calcium score is over 1,000, your risk of dying, I mean, and all-cause mortality results have been done, is more than 12 times a cohort your age that has a calcium score of 0. I mean, is that what you want? I mean, we don't know why plaques rupture, I'll grant you that. And actually, the calcified ones are usually not the ones that rupture. All I'm telling you is your risk of having a stenosis that needs a stent is predicted by your calcium score, and your risk of having an MI or dropping dead is predicted by your calcium score. Those data points are well, I mean, there's a lot of information, a lot of data that supports that. And I also can tell you your risk of death is on a gradation. It's a logarithmic scale. I can plot it with your calcium score. If I'm going to say 5-year all-cause mortality, so I'm not even going to try to say whether you died in an accident. I'm just going to say your risk of dying. It follows your calcium score very well. Okay? But what we're talking about now when a patient comes to the ER is, can we send that patient, does that patient have a stenosis that needs to go to the cath lab and be treated? And what we would like to know is, if I send them home, what's the risk of them dropping dead in the next 6 months? And we have good data that calcium scoring predicts both of those. Predicts whether, if they go to the cath lab, they're going to need a stent, 1. And 2, we have good data that says if your calcium score is 0 and you send that guy home, he's not going to drop dead in the next.
What portion of people would you actually say to go to the cath lab? And if it's such a good predictor, why don't we do it?
Yeah, I don't know. Yeah. Well, we've created, it's a monolith. We've created the Titanic. I mean, once you put all these systems in place, there's a lot of resistance to change. A lot of resistance at all levels. I mean, it's no one person's fault. It's just we've created this huge medical complex that runs these patients through from the ER to the OBS unit to the stress test, blah, blah, blah. I think it's going to change because I don't think financially, right now they're saying that I'm the devil, that I'm driving prices up. But I say if you apply this technology appropriately in appropriate patients that are likely to be negative, you have an opportunity here actually to do some good, and people don't understand that. Okay? Anyways, we got digressed a little. All I'm trying to say now is, does calcium scoring predict whether you have a stenosis? And the answer is yes. If I just use 90 as a cutoff, right here, if I use 90 as a cutoff, whether I could predict a positive cath event is about the same as stress echo or exercise SPECT. Okay, and the AHA actually agrees. Okay, the American Heart Association guidelines agree with that conclusion. Basically, it says a calcium score of 0 makes it very unlikely that you have a stenosis. Very unlikely. In fact, in 5 years, I've never seen a case. We've had no case with a 0 ever proven to come back to have a significant stenosis needing intervention. Okay, and it's the American Heart Association said in direct comparison studies, calcium scoring alone, forget about coronary angio, is equivalent to stress testing. Okay, and then what you want to know is the long-term outcome. And basically what I can tell you is there's good evidence that it's very highly predictive of not only your long-term risk of having a heart attack, but also your long-term risk of dropping dead. And stress testing, although it does pretty well finding stenoses, is not that sensitive for predicting this is what, and a lot of times that's what you guys want to know, because it's not patients that are so sick. What you really want to know when they come to your office saying I had squirrely chest pain a week ago is what their risk going forward in the next 3 years of dropping dead is. Of 0, yeah. In fact, we find that helpful because think about it. A diabetic should be considered high risk, and you might want to modify. I'm not saying you're going to let them do whatever they want if they're 0, but you might modify that a little bit based on if you knew their score was 0. Okay, so now let's just look. I know you're 5 minutes. Yeah. But let's look at a few cases here, and I don't think it's going to run anyways. Oh, yeah, it's trying to run. So we do an angiogram, which is basically, we inject the patients with contrast, and we use fancy 3D rendering to try to recapitulate what it would look like in the cath lab. So these are all CT images, and we're trying to do basically a surrogate for coronary cath so we can get the same data. And what we found is, again, negative predictive value extremely high when it's a negative test. It actually our pictures tend to overestimate the amount of disease. So if it's a negative angiogram, it tends to be very accurate. And the American Heart Association agrees with that also. I'm trying to rush here, going through. I just want to show you guys a couple. Here's a good example. A lady came in on a Friday who was not going to be able to get her stress test till Monday. So she's going to sit in the hospital for 3 days and start accumulating bills, waiting for her stress test. She has risk factors. She's very worried because she had family members with coronary artery disease. She has other possible, did she break a rib or something? Does she have reflux? The usual patient, myriad things. So we put her in the CT scanner because it's ordered because it's 4 o'clock on Friday and I can't get a stress test. So send him down to Douglas and see if he can do something with this lady. So we get our 3D data, and again, I'm exquisite when you have cooperative patients. The images, I don't need to say anything a lot of times. They speak for themselves. They are unbelievable. Unbelievable images when you have cooperative young patients that can hold their breath. And this lady has a calcium score of 0, and she has basically a completely normal coronary arteries. So I can prevent her from being admitted to the OBS unit to sit there all weekend and read Life magazine or whatever she's going to do. Get her $30,000 bill on Monday. So she has and again, what I tell people, you have a normal exam. I just did 2 tests that both have 98% negative predictive values back to back for you. Incredibly accurate. And here's another just case example. I'm out of time. The red light is on, so I'm going to... This guy actually had a negative stress test, and even in retrospect, looking at it, it's completely normal. His calcium score is 1,068. His risk of death is 12-fold that of his cohort age. 12 times the risk of dropping dead. Okay, and his CTA shows a stenosis. And again, this is a guy who enrolled in my protocol after he had the full workup and was going home told he was normal. I had to find him. I had to call him up at home and say, well, it isn't exactly normal. You have like severe 3-vessel disease. And again, I don't even care about the stenosis. I told you the stenosis isn't even the worst of his problem. The worst of it is that his stress test didn't tell him that your risk of dying is 12 times that of a normal person. Your risk of heart attack is probably 4% per year. And you need, incredibly, and that's another thing is our OBS units don't do a good job with follow-up. I mean, we're so like hospital-based with these guys that they don't really have a clear understanding of what they need to do a lot of times with their LDL afterwards. I mean, the fact that they did or didn't get a stent isn't what in the long run is going to save their life. It's what you guys do. And then finally, just one more. Here's a guy who had a negative stress test, but he was still having a lot of pain, so they gave me a chance because he kept coming back to the ER. And here's just his, it didn't work. Well, that's all right. Let's just go back and I'll end there. Let's just show that one. We'll take questions after that. Can you get that to run? No. No, that one. I just want to show the cine because it was just kind of a nice lit show. And I'll end after this one. No, I guess it's not going to run. Anyways, it was a cath that showed the right RCA stenosis. And then I think on time, just go. We'll just go ahead and fast forward. We're out of time here. Basically, I was just trying to show we can find other things. Actually, more patients who come to our lab have a non-cardiac diagnosis than a cardiac. They have pneumonia. This guy has a dissection. And again, all these things are things that you can pick up at CT. The stress test doesn't pick that up. And again, if you pick out the ones that are likely to be normal, I think you have a great chance to save money. very high negative predictive value, and long-term risk stratification, better than stress testing. And we can diagnose pneumonia, rib fracture, other causes of chest pain. All right, I made it through. I'm over. I know I'm over.